So, Lubna, you became a doctor for a reason. I'm sure there's a story there. But what is it about hypertrophic cardiomyopathy that made you come here?
So that's a very interesting and long story. I'll try to abbreviate it a little bit. So my HCM journey actually started in England, in London, to be precise. I was at the Hammersmith Hospital. I was working with a really brilliant cardiologist, Celia Oakley, who was an old school cardiologist whom, a lot of the cardiologists in the States know her, including Dr. Bono. Celia got me into HCM, and I was seeing HCM patients with her in clinic. I went to Hammersmith to do a research fellowship, actually. Then I got into doing nuclear PET studies in patients with HCM, where I was working with Dr. Paolo Camici from Milan, who came to London. And Paolo and I, churned out a few papers doing myocardial blood flow, seeing how the heart blood flow is in these patients with HCM. And we also imaged their beta receptors in the heart. So that was kind of something novel because we had these PET ligands to look at these things in the heart with this nuclear cardiology technique. So that's what got me really interested. The reason I went to Celia Oakley in Hammersmith is because in Ireland, where I did my training, medical training, I met one of my mentors was Dr. Sugru, who worked in the Mayo Clinic, and he worked with HCM patients. And he told me one day, why don't you present something about the genetic discovery in HCM? And that was Seidman's discovery. Dr. Seidman discovered the gene in that big Acadian population, the first beta-myosin heavy chain locus. It was not called beta-myosin heavy chain then. It was chromosome 14. So I had to present it at a conference. So I got really intrigued that one gene abnormality can change the life of a patient like this. So this was really fascinating to me. So I said, okay, I'm going to get into this. What else can I do? He said, okay, I'm sending you to Hammersmith to work with Celia. And I went with Celia Oakley and Paolo Camici and worked with them. And I met Carolyn Biro there, actually, in that institution. So, I was her doctor with Celia. So there, we took care of them. And so I saw a whole cohort of HCM patients while I was in London. So when I moved to the States, it was actually my husband who decided to move to the States because the sun doesn't shine in England. So that was his argument.
Okay.
We're going to the States. So I came here, followed my husband, then, came to Northwestern, and then found Bob Bono, who was really also into HCM, saw these patients. So that it was really then my idea to consolidate all our HCM patients into a specialized program of HCM. So, the rest is history.
The rest is history. And this is Tales from the Heart on the tail end of Heart Month 2025. It's February 27th. And I'm Lisa Salberg, the host of Tales from the Heart. And I am so happy to be here today with Dr. Lubna Choudhury of Northwestern, whom I've had the honor and privilege of knowing and working with for, it's got to be 20 years, Lubna.
Yeah, probably close to it. Yeah. We first, were surprised that we both knew Carolyn. Do you remember?
Yeah, I do. So let's let everybody else know who Carolyn Biro is, because it's not a name that we say a lot on the podcast. So quick backstory. In 1995, my sister passes away from mismanaged HCM. And interestingly, early in my sister's health journey, Bob Bono was actually an attending at NIH when she was there. So Bob's name is in her medical records. He did good work with her. So that was nice. Carolyn started an organization in England in 1993, so a couple of years before we got started, called Cardiomyopathy Association. And she was managing a patient advocacy organization in the UK. And she became a mentor to me, and she was an original founding board member of the HCMA. So she was a mentor, a best friend, she was my Carolyn, and she was amazing. And we lost her, and it was almost a year after her heart transplant that she had complications and she passed away. And that was like 2002 or 3, I want to say. somewhere, I think 2002 or 3. Sorry, I don't have that right now. She was a very important person to the HCMA, and she was a very important person to me personally. So I thank you for all the care that you gave her. And thank you for bringing her back up on this Heart Month, because she was an extraordinary woman who built an extraordinary organization that is now known as Cardiomyopathy UK. So if you've been involved with any of the programs in the United Kingdom with them, she's the grandmother, the godmother, the fairy godmother who made it all happen. So there's a little story on Carolyn Biro, my dear friend. So you came over to the United States after getting some really great training from some very impressive people. And then we start building up a center in Chicago. Tell me what it's grown to today, and then maybe we'll even take a little sneak peek at some of your colleagues.
Yes, so this is something I'm really proud of, and I'm thankful to my various colleagues who have made this possible over the years. So right now, we stand at about 5,000 patients or more in the Northwestern medicine system with HCM. So that's the entire Northwestern medicine. And how I know this is from the EDW, when it's an enterprise data warehouse that we can query to do some research projects or something, what's the denominator of our HCM. So throughout the system, just for those who don't know, Northwestern is not just Northwestern Memorial Hospital, but it has many suburban hospitals which are incorporated in the Northwestern medicine system. So in the whole system, we have over 5,000 patients with HCM. So we are really a large, center for HCM. And that has grown over the years through word of mouth, actually. Many of our patients have their family members come see us. Many cardiologists in the Chicago, Indiana, Wisconsin area have referred patients to us. I see patients from Michigan too, as well as Iowa, believe it or not. Some come to us from, I want to say, Seattle, who live there. The people live in Arizona come to us, DC come to us. So I've had people from various states who actually are living there, but they're flying here, to get their care. So, that tells you something that, they're willing to fly on a plane and come here. So we've had patients that have come from all these places, and mostly from the Chicago area, cardiologists who are not in the Northwestern system, but they have heard about us, and they just, send people, they refer people. So that, I myself and Dr. Bono were the two people who were mostly seeing HCM for a number of years. And then Dr. Bono went off to he became an editor-in-chief in JAMA Cardiology. So then all the new patients used to come to me. And then it came to a point where I was pretty saturated. So
pretty saturated is an understatement.
So we recruited some more of my colleagues, actually 3 of them, one of whom you will see shortly, will introduce you to. But, so we have 3 other people now seeing HCM patients with me because we have such a high demand. And I have to say that because, we are a all one-stop shop for HCM. We have a comprehensive evaluation strategy as well as a comprehensive therapeutic strategy. And that includes cardiac behavioral health, which is a huge component of Northwestern. And we are still pushing, because we don't have enough psychologists and therapists who we need for this disease.
Oh, we're going to talk about a project later, but we're not going to let everybody know about it yet because I'm still putting the pieces together, but I think you're going to be excited to see what we're building. So I'm going to do a little screen share here. For those of you who are listening, you're not going to see the video, but for those of you who are watching, you'll get to see a video that was submitted by part of the team at Northwestern for HCM Awareness Day. And I'm going to share screen. Oh my goodness, now I got to find the screen again. I thought it was already done. And we're going to show you, there it is, a little bit of the rest of the team. So with no further ado, we're going to hear from Doug. I was trying to start.
Today we're talking about hypertrophic cardiomyopathy. This is a disease that affects young people, it affects old people, it runs in families.
HCM is a common genetic disease, and unfortunately it's actually underdiagnosed and many times goes undetected. So it's really important to raise awareness about this because a lot of patients don't even know that they have it.
What it is a thickening of areas of the heart, and most commonly what's called the septum, which is in between the right and left pumping chambers, the right and left ventricles. And that septum essentially bulges into the path that blood exits the heart and can obstruct the blood flow out of the heart.
So your heart is working a lot harder than it should be, which can cause a variety of symptoms such as chest pain, fatigue, feeling like you can't do the activities that you normally were able to do.
So there's many medical and even surgical treatment options, and we have seen great improvement.
And we also get a lot of our patients involved in clinical trials for new and emerging therapies because a lot is out there to help discover new ways of treating the disease.
There have been a lot of advancements in the field of HCM in the last 60 years since the diagnosis was first noticed in the 1960s. People that have HCM now live as long and do as well as people that don't have HCM, and that's a testament to the medical therapies and advances that we've made. And we want to share those with people that have the condition. We first need to figure out if you have it. We have a multidisciplinary team here at Northwestern that can take care of all aspects.
Our goal is that somebody goes out and leads a normal life, needs minimal from us over the course of the rest of their life. But of course, we're here for a lifetime of care.
So tell us a little bit about the people we just saw on screen.
So yes, this is a sample of the people who take care of our patients here. So you heard from our HCM coordinator, Kayla Mueller, who is the first point of contact here. And she's going to reach out to patients, get their records, get a brief history, etc. Then you heard from some of our nurses, Abby and Caitlin, who are there, and they are very, very good at supporting us in our patient care efforts and, answering your messages and so on and so forth. Then you also saw two physicians in that video. The first was the surgeon, Dr. Doug Johnston, who is very well known in this field of HCM surgery. He's a very thoughtful surgeon and has, really remarkable techniques to do a really complete job of correcting the abnormal physiology that obstructive HCM patients have in the heart. So he does mitral valve repairs, papillary muscle repositioning, septal myectomy, maze operations, bypass surgery, whatever the patient needs, or the valve replacements, etc. So we really value his contributions to our program because, when people with HCM don't come like the book HCM, they come with a variety of things associated with HCM. They have concomitant valve disease, they have other things going on with their arteries, etc. They have arrhythmias. So Doug Johnston is a surgeon who can really tackle all of them at once. And, we really send him our really complex HCM surgery patients. And thankfully, we have, more expertise with surgery. Apart from Dr. Johnston, we have Dr. Mehta, who's another excellent surgeon who have operated on my patients with excellent results. So we have a few surgeons here who have the expertise on operating on HCM patients and HCM patients who have other things wrong with them at the same time. So that's who you saw. And Dr. Josh Chima is one of our junior cardiologists who joined us a few years ago. His focus is heart failure and transplant. And he's particularly interested in those HCM patients with overt heart failure who are heading in the transplant direction or who are non-obstructive, who just need to be treated for HFpEF. So he's been a valuable addition to our team.
That is fantastic. And I know Doug from back in his days, Doug Johnston at Cleveland Clinic. And when he called me one day and he said, I'm thinking of leaving, I'm like, where are you going? He said, Northwestern. I'm like, you know what? That's a really good idea. And I think you scored a win on that one. And I think you brought a lot of passion and a lot of experience. And I love that you have that resource now in the Chicago area.
Yes, it's very, and I know that when they were looking for a surgeon for Northwestern, I said, just make sure he can operate on HCM patients because we have a program.
Thank you. We definitely needed that. And I'm so glad you were able to operationalize that.
We lucked out with Doug, yes.
You did, and I'd like to think that a few conversations that Doug and I had helped get things moving in the right direction
I
to
think
get
you
the
nudged
help.
him.
Yeah. There was some nudging involved. It was nice
Yes.
nudging. We'll have Doug come on the podcast sometime and chat with him about things too. So I love getting everybody's point of view. It's been
Yes.
fun. So I'm gonna pivot and we're gonna talk about some trees. And
yes.
we got to talk about the trees. So why in HCM would we want to talk about trees? Because our friends over at Cytokinetics like to name all of their clinical trials after trees. So let's
That's right.
start talking about some clinical trials and start with the trees. So tell us what you're working on at Northwestern.
Yes.
And what
So I'll
trials.
tell you a funny story that when the Cytokinetics first started their trials, we're talking about therapies for hypertrophic cardiomyopathy. And, it was really obstructive and then non-obstructive. So it first started with the Redwood HCM cohort, if you remember. And the Redwood HCM cohort, the investigators meeting, we said we want to participate in that trial. So there was going to be an investigators meeting. So I tell this story because it's quite funny because, the investigators meeting happened to be in Miami, Florida, at a February date of what year, I don't remember exactly. It was quite a while ago, but it was in Miami, Florida. And I said, yes, sure, I'll attend the investigators meeting as an investigator. So then I look at my calendar and see, oh, I'm on a cruise that time. So what's going on with the cruise dates? Then I realized that my cruise actually docks in Miami, on the dates of the investigator meeting. So I go from the cruise port into the hotel to attend that Redwood HCM investigators meeting.
Well rested.
So therefore, they all know me as the one who came from the port to do this. People usually fly to Miami, I'll have you know, but not
a boat. A big boat
to Miami. So, then we got involved in the Redwood HCM study. We recruited a lot of patients. In fact, I got an award from the Heart Failure Society of America for recruiting so many patients in the Redwood trials. So I didn't know you could get an award for recruiting patients, but there you go. So we got it.
I might have to look at that award and see if we can offer one.
So anyhow, the Redwood really paved the way for the next series of trees, as Lisa calls it. So the next series of trees, we got the Sequoia HCM study, right? The big Redwood tree. So the Sequoia HCM, showed spectacular results and, that got published in the New England Journal of Medicine. So, we were very excited about that. And that was in obstructive HCM patients who had really remarkable symptom improvement and lowering of their gradients, in a substantial way with this drug. So this was aficamten, and it really showed its efficacy. And then we started doing enrollment in patients for Maple HCM study. So that's Maple and other trees. So that is actually comparing head to head, aficamten with metoprolol, which is the most common workhorse drug for hypertrophic cardiomyopathy. And, the idea is to see with a standard of care drug, how does aficamten do? Aficamten, as you know, is a cardiac myosin inhibitor, and it works to reduce the force of contractility of the left ventricle at the myosin level, at the cellular level of the heart. So we want to see how it compares with the beta blocker. So it's a very exciting study for us because it would really change the paradigm in how HCM is treated if we can get the results of the Maple HCM study. So that's the study I'm most excited about to see how that will go. But in addition, the trees are not gone yet. We still have acacia.
More trees.
Yeah. So Acacia HCM is a study in non-obstructive hypertrophic cardiomyopathy patients with aficamten versus placebo. So these are patients who do not have a gradient, so about 30% of our patients, who still have symptoms. They're short of breath, they are intolerant of exertion, and something is going on. They have heart failure symptoms, sometimes with overt volume overload, sometimes with not. And these are patients who were eligible for the Acacia HCM study. And believe it or not, it was so popular with our patients that the study closed quite quickly. because they finished enrolling the number they set out to enroll. So therefore, you are no longer eligible to enroll in it, but we eagerly await the follow-up and the publication of the results. So that's going to inform us whether this class of medications, the cardiac myosin inhibitors, are truly useful in non-obstructive hypertrophic cardiomyopathy, which is really the unmet need in therapeutics of HCM, that we really want to do more for this group of patients, apart from just treating them, as a lump, as heart failure with preserved ejection fraction. We've been there, done that, but we want to see if there's something specific in HCM that this drug does for this group of patients. So that's, really exciting for us to wait for the ACACIA results.
So we're waiting on that. We do know that there is a PDUFA date, so that is a date that the FDA is expected to make a determination on aficamten in the obstructed population, and that is in September of 2025, so this September. You're also involved in the MAVA long-term extension study, which is for Bristol Myers Squibb, mavacamten. I tried to put Camzyos and mavacamten together in one word. It didn't work. So what are we learning out of MAVA LTE?
Yeah, so MAVA LTE, I think the major message is it's safe for the amount of time these patients have been on this drug. Because, remember that patients have been on this drug the longest. So we have the longest data on cardiac myosin inhibitors from the MAVA LTE study. We are having a similar study, FOREST HCM, with the aficamten patients, but aficamten, started later than mavacamten, so we don't have quite as many years on FOREST. But I'm happy to say that the FOREST results are also very promising. For the FOREST results actually show that, it is also a very safe drug and it is effective years down the road. So really, what we want to see in these long-term studies is that there is no adverse events and the patients are still getting the benefit, that their gradient is still low without lowering their ejection fraction. They're the two big things that we follow in the long-term studies. So the longer the study, the more reassured we are that they are safer to use.
The other thing I will end with on the myosin inhibitor conversation, just so people are aware, in April, the FDA is expected to provide another PDUFA date. I didn't realize they did these as PDUFAs for a reevaluation of the REMS program that is associated with Camzyos. So there may be some changes in the surveillance aspect of the drug. Now that it has been on the market, it'll be 3 years in April. So we'll learn more there. Stay tuned for more information. As soon as we hear something, we will bring it to you, I promise. You're also participating in another trial that just a little over a month ago, we held a webinar on for Lexicon. And this is an SGLT1, SGLT2 combination therapy. And Carolyn Ho and Charlene Day came and talked to us all about the mechanism. So if you want to learn about that, you can go watch a previous webinar in our archive. But you're also recruiting for that trial. You want to tell us a little bit about it?
Yeah, it's the Sonata HCM study. And it is really a study where, I tell patients that we know about this drug. This drug has been around for a while, and it is effective in other types of heart disease. What we don't know is that how effective it is in HCM. And, whether you have obstructive HCM or non-obstructive HCM, you are eligible for this study if you have symptoms. If you have no symptoms on ordinary exertion, you're not eligible. So if you have symptoms, please contact us and, we will screen you for it because, we're very excited to actually gather data on this class of drugs, the SGLT2 inhibitors, SGLT2 and SGLT1. It's a dual inhibitor, this particular drug. But it's like I say, it's like the Jardiance type of drugs that we've been using. Jardiance was developed, as you remember, for diabetes, but then cardiologists jumped all over it because it was so effective in heart failure. So that spawned, generations of this class of drugs. They're very effective in heart failure. Are they as effective in HCM? We don't know. That's the reason for this research.
It's interesting because we've seen a lot of the, Farxiga and Jardiance in this class. I've seen a lot more people be placed on this, especially with non-obstructive HCM and more heading towards
They
advanced
do
heart
it
failure.
empirically because they think they're treating HFpEF. So if it's useful in heart failure with preserved ejection fraction, HCM usually behaves as heart failure with preserved ejection fraction, non-obstructive HCM. And so, we try it empirically, but we have zero data on this. So Sonata HCM is an attempt to actually gather some data.
And I'm happy to say that we were hoping to recruit about 125 people for their trial. And we have exceeded that, and all of the referrals will be sent out by end of this week. And we've gotten over 150 respondents who are interested, and we have a site for them. And I have another 100 people that are interested when new sites open. So I do not think we're going to have any problem at all populating this study. It looks promising. And honestly, as a patient looking at a clinical trial, it's relatively easy in comparison to some of the other trials that we've done.
Yes. So the highlights are that you don't have to do a CPET for this one, so that's good, and you don't, it's not a long study. I tell my patients that, it's a short trial as clinical trials go. It's only 6.5 months. You have to commit to that. You have a 50% chance of being on the real drug versus the fake drug. So they look the same. You and I will not know what you're on, so we don't want to bias our results. But it is, a very doable trial for most of our patients because the criteria are not so stringent, but there are some, exclusion criteria, which, I recently learned that apparently malignancy is an exclusion if you ever had a malignancy, but apparently they're doing a protocol amendment. So I don't know if they're going to keep that exclusion. So some of our patients, that we got referrals for, could not qualify based on that. But, if the amendment goes through and they change it, then patients with prior cancers will be eligible because there's no signal for malignancy with this drug.
Fantastic. So we're heading towards a couple of other trials. Are you doing any other trials in myosin modulators or any other class at this time?
No, not at this time.
Not at this time. So that answers Ross's question. Leslie, who's joined us, she's a newly diagnosed individual, and I'm sure there's a lot of questions floating through your mind, Leslie, while I have you here for a second, and I hope you're still with us. I encourage you to call the office at 973-983-7429 or visit our website, and you can set up an intake and navigation call, and we can help you start to learn the lay of the land, the language, and help you unpack the materials that you'll need to have a very informative conversation with your chosen healthcare provider. And we can also we can also work to help find you a good center of excellence partner in your journey. So, Jardiance was a game changer. Let's see what he has to say. Oh, Laura, sorry. Jardiance has been a game changer for me. I was skeptical because I knew about it for diabetic. Once again, thank the HCMA and Dr. Zanker. Well, I'm glad that it worked for you, Laura. That's fantastic. And we didn't pay her for her endorsement. No, I'm only kidding. You're welcome, Leslie. I'm glad that you're still with us. Oh, Elisa, you're just diagnosed too? Well, girlfriend, give us a call. Same 973-983-7429. Or you can visit the website at the number 4hcm.org. Ross, maybe you can put that up there for scheduling an intake appointment. And we'll give you a link in just a minute in the comments. And you can join us once a week, typically in podcasting. You can join us at least once a month in a webinar. You can join us weekly in discussion groups. We are available wherever you want to meet us. We're here to help you through this journey. Okay, Lubna. Why is it so important? You see, we have two people here who were just diagnosed, so they're new to finding us. Right now, we know that between 150 and 300,000 people in the United States have a diagnosis of HCM. Of that, maybe not all of them have had optimal treatment so far, but we do know by diagnostic code they're out there somewhere. But we have about 1 million to 1.3 million people in the United States who could be diagnosed with HCM. Why is it important to find them?
So this is a very important question. And this is primarily because I want to say that it sort of flies over people's radars. They just really do not pay attention to the symptoms. And many people are not aware that HCM can present with symptoms that mimic other types of heart disease. And it really is, how much can I say? I've seen patients, I see a lot of patients, 90% of my practice is HCM now. So I can't tell you how many times I've heard that people have been seen for years and years and years with echocardiograms years and years and years, and they've had everything. They've had caths every other time. They have had an angiogram, this, that, and the other. And nobody paid attention to the asymmetric septal hypertrophy that was in every echo that came back. That was ignored. So, there's two things in this. One is the patient unawareness that this could be HCM. I'm fainting, I'm lightheaded, I'm short of breath, can't climb my stairs, I do laundry and I get out of breath. What is it with that? I need to see a cardiologist. Or the patient ignores them, I'm just getting old. That's it. It's with age, right? And it's the providers. The second part is the doctors who are seeing you are not used to seeing HCM. So they're really it's not in the front of their minds that what you're describing could be HCM. So, we need to educate both patients and physicians alike, in my opinion, that when you see a constellation of symptoms, think about it. If you think about it, you will do the right tests to discover it.
The most common misdiagnosis associated with HCM before you find out you have HCM. So what did they tell you before HCM? A murmur. You have a murmur. It comes and it goes, this murmur. It's an unusual murmur, but I wouldn't worry about it. Well, I would. So that's number one that you hear a lot. Number two is athletically induced asthma or other forms of asthma that don't really meet the asthma definition, and you've not had a pulmonary function test to prove asthma or no asthma. You could also have been told you have anxiety or depression. You could be told that you have mitral valve prolapse. All of these things are kind of there, but they're not. But if you see asthma and a murmur, get an echocardiogram. That's my hope in the world, that when they see that together, they take the necessary action. Yeah. So if we diagnose them in time, what to you is the most important thing we can do for them? Risk assessment or symptom management?
I think they go hand in hand. We can't do one without the other. So obviously we want to know what they're experiencing. And if they're completely asymptomatic, doesn't matter what symptoms they have or not have. We have to risk assess every single patient. So we have to know what your risk is. So don't worry if we're doing tests on you and say, oh, I'm not symptomatic. Why is the doctor ordering all these tests? We're ordering it because we want to get a better handle of whether you are at increased risk of dropping dead or not. That is a blunt way of saying it, but there are some people who can have an increased risk of sudden cardiac death. And if we are not aware of that, we're not going to look for the signals that send us down that path. And if we completely ignore it, one day we will hear that they did drop dead. So fortunately, sudden death is very uncommon in hypertrophic cardiomyopathy nowadays, because we have a lot of therapies that we can prevent sudden cardiac death. We can actually implant defibrillators in you, which have been proven to be the best way to prevent sudden cardiac death. We used to think certain medications do that in the past years, but that has found out not to be true. So if you're on amiodarone, you're not protected. You need a defibrillator if you're at increased risk of sudden cardiac death. And you need a cardiologist with experience in hypertrophic cardiomyopathy to assess your risk of sudden cardiac death. I liken this to storm clouds, So if you see storm clouds in the sky, you know it's going to rain, right? So it's going to rain. So I'll give you some examples. One of my patients had advanced HCM with systolic dysfunction. And with systolic dysfunction, I kept nagging him. He was young, in his 30s at the time. I said, you need to strongly consider a defibrillator, blah, blah. No, whatever. And then he arrested one day. His wife resuscitated him and got the EMS there. And when he woke up in the other hospital before he was transferred to us, he said, "Don't tell Dr. Choudhury." That was his response. So then another one kept refusing an ICD, and he was, since a teenager, he was playing basketball, passing out, fainting. And I said, and he had a very thick heart muscle. So I said, you really need a defibrillator, and tried to convince him for years. I was nagging him. So finally he agreed. Within 2 months, his ICD fired appropriately. And and how I got him to agree, I said, you have a young daughter and you need to be around for her. So that's how. So, you have to contextualize a patient's, hesitancy, but what is important to them in life? What do they want to live for? And if there is something that you want to live for, then listen to your doctor.
I couldn't agree more. There's an interesting little story being formed here in our comments. And Dawn, honey, we're here for you. We're going to get you through this whole journey, and we're here for the long haul. We've been here since 1996. We're not going anywhere. We've got you. But there's something really interesting in her story here. We'll get to that in just a moment. So she says, we talked about the misdiagnosis. She's been diagnosed with a murmur, asthma, anxiety, and depression since 2020. So we're working on 5 years of that. I want you to speak to somebody who has truly got asthma and why maybe they don't want to take a beta blocker if they have true asthma. Can you take a beta blocker with asthma?
So yes. So the thing is that beta blockers come in different flavors, right? So there is, non-selective beta blockers, which are bad for you in asthma because they can aggravate asthma, and then the selective beta blockers, which don't affect it so much. But in patients with severe asthma who have hypertrophic cardiomyopathy also, we tend to shy away from beta blockers, and we try to treat them both more with calcium channel blockers, non-dihydropyridine like diltiazem, verapamil, that kind of drug. But, they can exacerbate asthma, especially if you've got severe asthma or if you're on a non-selective beta blocker. And certainly asthma shouldn't cause a heart murmur. So, you need to put those two things together. I hear patients tell me, I've had a heart murmur since I was 15. And so what was done about that heart murmur?
Not much.
Apparently nothing.
Right. We get that. So there's a comment, and I want to take some time to dig into this, Stacey, because what you're bringing up is important. And there are some triggering words here. So I will put trigger warning out, because many of us come from families who have experienced sudden cardiac arrest of a family member, a loved one, a child, a sister, a grandfather, an uncle. And there's this challenge between the actual prevalence of sudden cardiac arrest in HCM over all of the people with HCM, and then there's the personal experiences. So Dr. Choudhury correctly stated that it's actually uncommon to have sudden death in HCM. It's not the most common thing that happens. Otherwise, we would all probably be gone by now. But her son passed away at 21. So she's not comfortable with the concept that we're stating sudden death is uncommon. But I want to talk about real numbers. And your experience, Stacey, is real. Your pain is real. Your loss is real. It's not uncommon to you. But for everybody that's listening, and I'm going to run through some numbers here. Lubna, tell me if you agree with me or they're a little bit different than I'm stating, because I'm going off top of head. We know that we put in a lot of defibrillators in the United States over the past 25, 30 years. And probably about 20% of people with HCM have devices at this time. And about 4% of them, 4 to 5%, will go off in is it lifetime or annually? Is that annually or lifetime? Forget what the number.
No, it's supposed to be annually.
Annually. So of all of the people, of the 20% who get the high risk evaluation triggers, very thick heart, NSVT, family history of sudden death, lots of scar on MRI, etc. And you can find all of that information on our website. of those people, the events of sudden death are actually still uncommon, but common enough to make us want to protect people with defibrillators and also have good community responses with AED, CPR, and good emergency response programs. We're not saying it doesn't happen, but for those who get risk assessed in today's world, once you know about the diagnosis, we can do something about it. But Stacey, we are not taking away anything from your loss, and it was not uncommon to you. It's unfortunately very common to you, as it is with my family. So I understand what you're saying, but statistics and probability are what we're living off of here, and I hope you can understand that nuanced difference, and sending lots of respect to you and a lot of love for your loss, and we're very sorry about that. So anything you want to add to that, Lubna?
No, I mean, Stacey, I feel your pain. I mean, nobody should have to bury their children. I think that's the worst form of grief that we can we can experience. But I would say one thing, that sometimes it's unavoidable. Nobody knew anything about in the family history or anything. But, most cases of sudden cardiac death, I would say, are preventable if you seek care at the certain time. So that's why we talk so much about awareness, because, it doesn't matter. I can't tell by looking at your face what your risk of sudden cardiac death is, right? I need to evaluate you. And so if you give me a chance to evaluate you, then I have a chance to protect you. So many people don't get that chance. And that's really what I'm trying to say, that, we need to be more aware as a community, that we need to be more aware and get care. Because for some, I would put it this way, that, for some patients, we see them first. The first time I see them, you're getting a defibrillator. Because it's the thunderclouds. I see the thunderclouds, it's going to rain. I've got my gestalt. I've got so many years of seeing HCM patients. I can see it. I can recognize it when I see it, their risk. Okay, that's how some people are. Some people are less obvious at high risk. So we'll do a little more. I'll wait for few more things before I decide. So, but again, you can see the mind working to try and come up with a realistic assessment. This is from my experience. Now, risk stratification, as Lisa alluded to, I think personally we're putting in too many defibrillators, to be honest with you. But I'm not sorry about it. Do you know what I mean? I'd rather be safe than sorry. As I tell my patients that you were 95 and said that Choudhury put a defibrillator in me and it never went off. But you know what? I'm not going to be sorry, because of what I see today and the understanding that I have today. My gestalt is you're going to need it. You're going to benefit from it. So, and the European guidelines underestimate risk. We try to, we are more sensitive in our guidelines. So we kind of, tend to place more defibrillators. We're not constrained as much by the European. I've worked in the National Health Service in England, so I know what it is like. So I think that, we are very proactive about finding people, assessing their risk. And if you're not at risk, you just see me once a year, say hi and bye, and that's it.
So, Stacey, I'm going to take your comment here and turn it into a call to action. So how could we have been spared from this sudden death? I wish pediatricians were looking earlier at kids' hearts for this, and thank you. You're welcome. So I agree. And I'm not going to tell you that I have the definitive answer. I think this is a stepped question. And what we have created here at the HCMA is a sample policy language document called the Children's Cardiac Safety Act. And our goal is to have every well child examination in the United States include cardiac components and look for heart disease in children and families. We do this for student athletes. We do a pre-participation screening exam to rule out who has heart disease and who should be getting additional services and health evaluations, medications, or therapies before it's safe for them to participate in sports. Well, let's look at some data. Out of all the kids who die under the age of 24, so we're talking college age and beneath, basically. If you look at all of that data in something called the CDC Wonder Database, you can see how many kids die per year from each diagnostic code. And we know that about 125 kids per year are dying with HCM as the diagnostic code on their death certificate. Of that, we know about 20% of them are dying during sports activity or while enrolled in a sports season, which means 80% of them are not getting a PPE sports evaluation. So why the hell not? Why are we treating children differently based on whether they play a sport or not? So we don't want that to happen. We want every child to get the opportunity to evaluate family heart health history and individual signs and symptoms to evaluate whether they need to be seen by a cardiologist. We have a healthcare crisis in this country, and nobody can deny that it's going on. So we don't have the resources to bring every kid in and do an EKG, an echocardiogram, and a full checkup with a cardiologist every year to 2 years because we don't have the resources. So we have to try to find who is at higher risk based upon signs, symptoms, and existing knowledge in the medical realm. We know where these families live. We know what the signs are. They may not be completely apparent to you, but a doctor should be able to put the pieces together. If an aunt had heart failure and your mother has a pacemaker and you've passed out twice, well, that's something you need to talk to your children's doctors about. Not wait until something happens to you and then take that information and do something for your kids. You are the genetic material that is 50% of your child. What affects you may affect them. So I encourage you all to get involved with our Children's Cardiac Safety Act initiatives. Hopefully by the end of today, we will have a law passed in another state. We already have New Jersey. We're working on Virginia right now. And we have bills working in Rhode Island, and we're getting bills in we have a bill in Massachusetts. We're getting a bill in Minnesota and Michigan and a bunch of other places. So that's where the difference is going to come. If we start talking about it earlier and making sure every pediatrician knows what they're looking for, give them some training, and then we can find these kids in time to get them the treatment that they need. So please join us. Join us. We will have electronic ways for you to participate where you can just send letters to your state house. We're going to need everybody to get on board with this one. So I look forward to working with you all on this. We're working on a bill in Illinois right now. So if you're in the Northwestern area, Dominic gave the testimony at the legislative briefing for the Illinois State House earlier this week. So thank you to your colleague. We are doing things, and we're going to need all of you to help us make this a reality. It's happening now. It's moving. We've got some traction and energy. We're just going to need a couple more hands to raise this up. So we don't want to see any child lost. We don't want to see any family member lost. Yeah. We want families to stay whole.
I think you said one very important thing, that the misconception is that it's only kids who play sports that are at risk. And this is completely untrue. And that's why we need pediatricians, because they're the first line, to listen to kids. If they have a heart murmur, have a very low threshold for sending them to a pediatric cardiologist. Because you don't know what that heart murmur is. They could have early HCM, or something else.
They could have a PFO. They could have they could have a lot of different things. A murmur
murmur is not normal in a kid. So that should be, before it's kind of dismissed as, especially if the kid is, in their not a neonate, that they're just kind of going to school and school age, and they're going to participate in various sports. But, these sudden deaths don't occur just during sports. People could be coming down the stairs and die. They could die in their sleep. So pediatricians should have a lower threshold of referring people for further evaluation if they don't want to do it themselves.
You never quite know where a live podcast is going to go because you don't know what the comments are going to be. And we have Ross back there pulling up links so we can keep the conversation on task and give the resources we need. And thank you, Lubna, for kind of going with the flow of the conversation today. That's the fun part of Ready to Fight in Florida. I think we're working on a bill in Florida as well. It's not necessarily knowing, so let's pull this up here for a sec. So Ready to Fight in Florida, happy to have you on the team. We'll get you in here. I believe all checkups my son had, but no one ever asked about things that could have saved his life. Yes, my son died washing up for dinner with his grandparents. Oh my God, that's so sad. I'm so sorry. we've got to do better. And part of the doing better, Stacey, is telling your son's story. And sometimes we can also go back into the medical records and see if there's any hints. We're not saying it's malpractice. We're not trying to vilify the doc for missing something, but we can learn a lot from those who aren't here anymore. And what can we learn from that file? Was there a moment that should have been acted upon, and can we use that as a teachable moment? This is the way we have to think. We have to think about fixing the system that we're living in. We can't create a new one. Technology isn't there yet, but technology is going to come and assist us soon. And one of the things that's going to help us with technology and assistance in screening, AI technology and and electrocardiograms are going to be a really good first signal that could be inexpensive, but it's not ready for prime time yet. It hasn't been fully vetted in teenagers. It needs approvals in that age group. But I think technology can come and help us, but it's not there yet. But I can assure you, I am talking to the people and doing the things behind the scenes to bring these technologies to reality. Lubna, I'm going to let you hit this one. Why would pediatricians or ped cardiology say a heart murmur is normal as a part of growing and it will go away?
There are some heart holes in the heart, like VSDs, that can close spontaneously, that can cause a murmur. So that's probably why they say that. But, how do you know it's a VSD? Did you ever get an echo to show that? I mean, I would say, before I say that it's going to close, I would do an echo. Doesn't hurt to do an echo. Just see that, oh yeah, there is a hole in the heart. Okay, we'll check a few years later, it'll close. That's why he has the murmur. I would feel much better about doing it that way. But, I'm not a pediatric cardiologist, but that's how I would approach it.
Ross, if you could pull Julie's information up. So those who there's a couple of people here who seem really interested in helping with legislation. So let's get them hooked up with Julie Russo, our legislative lead, who can help connect you with what you need to do in your state. The first step is to get a bill number. You get a bill number by getting a champion. So it could be your own state senator, your assemblyman, however your form of government works. You get a bill in one house, then we find a partner bill in the other house, and then they go to committee, we provide testimony, we get to a vote. Every state works a slightly bit different on how, when they start, when they end, when can you introduce a bill, who can introduce a bill. There's lots of rules, but we'll figure them out with you and help you work with your state to get this moving and hopefully get it passed. We can't do this alone. The constituents that we are working with that live in that state, they're the ones that are going to be the true leaders and champions to make these things happen. So if there is anything that you want to get involved with, we'll get Julie and she's going to help you out. And Ross will put that up on the screen in just a few minutes. So Elisa wants to know, Dr. Choudhury, how do you feel about Camzyos? And it says, I have 40 mm. So I'm going to guess she has an outflow tract gradient of 40 millimeters of mercury. And if that's not correct, Elisa, you can call the office and we can talk about it more. But what do you think about Camzyos and myosin inhibitors in general?
Yeah, so I think the Camzyos and myosin inhibitors in general are a great advance in the treatment of hypertrophic cardiomyopathy, especially obstructive HCM patients. We can say that we have definitive data now that this class of drugs really works in removing patients' symptoms very effectively because it reduces the left ventricular outflow tract gradient very effectively. So they no longer have obstruction when they use this. So basically, they keep, the mitral valve is moving the wrong way. So I tell people you should look at the valve like a door, open, close. One part of the door is going this way instead of closing. So when it goes this way, you get obstruction to blood flowing out of the heart. This is the outflow tract. But Camzyos keeps the mitral valve where it should be and doesn't, prevents this abnormal movement. So it is a very effective drug. And a lot of my patients are on it. They really benefit from it. And I think this is a real advance in the treatment of hypertrophic cardiomyopathy. That being said, you need to go to a center of excellence where they're used to using these drugs in, fairly substantial numbers of patients and who know something about who not to give the drug to. That's what I tell my patients, that, I've been really very much involved in the drug trials of Camzyos myself, as by way of disclosure. So I know exactly which kind of patients should not be getting this drug. So therefore, I had an example recently. We presented it at our complex HCM conference today, and I said, I presented it because I wanted you to see who should not have gotten this, so you need to see a physician who knows that.
So there's an interesting other comment on this thread, and I want to talk about ultra high gradient. So somebody else is posting that she's got 162 millimeter mercury gradient. If the gradients are over 150, is there a different strategy to how you're going to manage them?
I would say no, with a caveat, because the thing is that, these gradient reductions, we have seen it by percentages in these, patients, and they are very effective. Now, if you have a very, very high gradient, what can happen? Your gradient will decrease with Camzyos, right? So the question is, how much will it decrease? Will it decrease enough that you become asymptomatic? So I'll give you an example. If your 162 millimeter gradient became 70 millimeters with Camzyos, for example, just speaking, are you going to be symptomatic at that gradient? I don't know. You'll have to tell me as the patient. So if you're still symptomatic, then Camzyos, provided you're on the max dose, is not working for you. And then we need to go to another strategy. But remember, it's a stepped approach. So you start low, go slow, and you build up to the maximum. It's not a drug that you keep piling on like some blood pressure drugs and that, so it doesn't work like that. So that's one strategy. You'll know soon enough if you can, A, tolerate the drug, B, is it working for you? If it's not working for you, as I said, it is one option in the armamentarium of options that we have for our HCM patients. There is surgery, there is other therapies, etc. So we have to, and some people will say, no, I don't want to be on a drug for life, because Camzyos is for life. Yeah. So if you're not going to be on the drug for life, I'm going to send you to septalmectomy. That might be the best option for such a high gradient.
That's where I was leaning towards. There is still a role for surgery.
Absolutely.
HCM. Some of these anatomies, the drugs are great. The drugs are fantastic. I also helped in the early clinical trials and recruitment and building the trials and the protocols and helping understand the patient journey going back to 2013, 14. So we've been at this a long time. This is not new stuff to us. We've been dealing with this for over a decade. But myectomy, we've been dealing with for a lot longer. It's got a really good outcome when done in a high volume center by a skilled hand, which you have there at Northwestern. I would be very careful as to where you're going for a myectomy. I'd be cautious as to who I'm allowing to start me on a myosin inhibitor, but I would be absolutely vigilant to ensure that if I was going to have surgery, it is with the highest volume surgeon I can get in my network. And if you can't get a high volume surgeon in your network, you call us and we'll fight for you so you get to a high volume surgeon. The surgery, Leslie, is called a myectomy, and you can learn about it on our website. Dr. Choudhury has a patient to get to, so we're going to wrap this edition of Tales from the Heart. I'm going to thank all of our sponsors. I'm going to thank Ross for dropping links, and Joey, who's going to do the editing on this on the other end, and Julie, who's going to turn it into AI clips so we can put clips out on the web. For all of you who have participated in this session, thank you very much. I hope you call for an intake call. And on that note, after HCM Awareness Day, I'm scheduling a little too much on my calendar for today. I'm going to go get a massage tonight.
You deserve it, Lisa. Thank you
so much. Lubna, thank you for not only your time today, but your partnership over these years and all of the service that you provide to our patients and your entire team. Thank you very much for your partnership and your friendship.
Thank you so much. Okay, be well and bye to all.
Have a good day. And this is our last event of Heart Month.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.